Hi, my name is Dr. Deborah Joy Perez, and I am the Chief Equity Officer at USP, United States Pharmacopoeia. I am delighted to be speaking with you today about the effects of intersectionality and social determinants on health and health outcomes. I specifically want to talk about structural racism and the things that really exacerbate social determinants of health. I know you've heard from others and can give you an overview on things like structural racism writ large. I want to talk about those things that really matter in institutions that make the process of undoing racism possible, right? So in my mind, when I think of social determinants, I think about life. I think about jobs, education, resources, income, those things that are directly correlated and impact health. That could be everywhere from where you live, certainly where you work, and what we used to say at Robert Wood Johnson Foundation, where you play. So the space matters, environments matters, neighborhoods matter, access to resources matter, and all of this exacerbates with the element and the addition of racism, right, and structural racism. In the work that we do at USP, we're very explicitly focused on operationalizing systems that advance equity. In other words, undoing unintentional bias, really building consciousness around those biases, really focusing on behaviors. One of the things I often stress to my colleagues is that feelings do matter, and the experience of patients in terms of whether they feel psychological safety and trust and transparency, all of that matters in their relationship with regard to outcomes. But what matters more is the physician behavior and the actions that they take, the things that they say to bring comfort and trust to the patient. So this issue of operationalizing equity, which is the counter of the structural systems in place that endure and support racism, are really focused in 5 areas. One is, what is the governance that is unintentionally or intentionally contributing to structural racism? Where is power sitting in an organization? Who oversees the programs and the inputs related to undoing racism and to advancing equity? The second area is around accountability and metrics. What are the ways in which you can demonstrate using data the impact of structural racism? You don't need to look very far to just use race as a way to disaggregate the health outcomes of patients. So those things that relate to health and social determinants will manifest in patient outcomes. So if you're seeing differences between African American, Latinx, Native American, and white populations, that's an indication that there's something wrong in the system, right? Because not the care and the support is not equally distributed. The third area is in the communication. One of the things we know from research done many years ago, going now on 20 years by physicians, Dr. Cooper at Johns Hopkins, is the patient and doctor relationship and how communication happens really matters, right? And so how we talk about the patient's needs and interests to really lean into kind of what is the environment that they're in, what other things might be contributing to their ability to kind of achieve good health, where they live, going back to kind of structural and geographic issues of racism. All of that really matters in terms of communication. The fourth area that's really important is, what is the system, the people, processes, and system of any entity, right? And how does that advance equity? To what degree are the policies reflective and considering issues of structural racism and systemic bias? And is there anyone kind of really held accountable to focus on changing those policies and systems, right? And then finally, how do we build the capacity of physicians, healthcare worker, and affiliate personnel that interact with the patient to make sure that they understand the impact of structural racism. They understand the impact of social determinants. And all of this can be viewed through not just an equity lens on kind of how to achieve equity, but from the intersectional lens. One of the things I really wanted to emphasize in this conversation is the danger of this kind of whataboutism. And this is speaking to kind of efforts to address racism are often derailed when there's a question raised about what about income? What about poverty? As if poverty is not reflected in focus and issues of racism. So kind of what we understand is you have to consider everything from like sexual orientation, race and ethnicity, religious affiliation, abilities and disability, whether they be physical or neurodiversity issues. All of those things interact with the experience of each of the factors of social determinants. So kind of the important thing is to acknowledge that unless you're willing to have that courageous conversation to really call out and explicitly address where racism exists, you can't undo racism. I often say that you can't kind of achieve equity if you can't talk about racism and how it manifests, right? And I guess maybe it's worth kind of reflecting on the definition of equity, and so I often use this meme that I found on LinkedIn that talks about those definition of those 5 terms: diversity, equity, inclusion, belonging, and ally. Diversity is a fact. It's something that can be measured. Equity is policy, is the things you do to ensure fairness. It doesn't mean equality. It doesn't mean giving everyone the same. It means kind of giving people what they need and tailoring the intervention and the resources and the investment based on how far they have to go to achieve excellent health, right? The focus and kind of conceptual models often described as targeted universalism, right? Inclusion is an action. It is intentional. It's something you do to make sure that people feel seen and heard. And belonging is what you get when you achieve those first 3: diversity, equity, and inclusion. And I often say to folks that in this work of undoing racism, in this work of addressing structural racism, and really being mindful of intersectionality and social determinants, it requires allyship. And what is an ally? An ally is someone who uses their power to operate in solidarity and as a member of a dominant group, using that power to support someone in a non-dominant group. So you can be an ally and be a white male to a white female. You can be an ally as a person with ability to a person with disabilities. You can be an ally of someone from a dominant religious belief to a non-dominant belief. All of us have the capacity within us to be an ally. So that's what I want to say about this very important topic of structural racism, intersectionality, and social determinants of health.